Thanks, Kevin. Good morning. So I thought this was going to be a little more like you afternoon. You guys are going to be like surgery's the best and GI has no role. And so now I feel like you just like teed it up for me to tell you how, how it's done. So I enjoy being here. It's interesting to come to a big meeting and I know like Jeff Marks and Kevin and that's kind of it. So versus my GI meeting. So I'm going to talk about endoscopic necrosectomy. Let's see. Okay. And I have nothing to disclose. I will, I should have put this on for the 7 seconds when I was chatting. So like surgery, we've come a long way since I finished my training in early 2000. So when we first started managing pancreatic fluid collections, we were sort of more looking at the ones that are pretty liquid looking, like pseudocysts, where we could start with these plastic stents and be pretty successful. The procedure was pretty complicated. The nurses really hated it. We all sort of started with an echo endoscope. If you didn't do EUS, you would have someone who did it, or you'd go in and just look where the bulge is, and then we'd use ERCP devices and try and make a hole with a needle knife or sphincter tome and make it big enough to get a balloon in and balloon dilate, and then the fluid's coming out and you can't see anything, and you're under fluoro and you're sort of hoping you were in a good position. And it was very sort of something always happened that went wrong. And then we sort of moved to, we got a cystotome, which was a nice sort of one-piece device that could make a 10 French hole. Then the balloon could go in, dilate the tract. But we still had sort of issues with sometimes with visualization, and things would just invariably go wrong. In fact, one of my first ones at the VA put the whole double pigtail into the pancreatic fluid collection. So, it just seemed like it was a complicated procedure. And so people were doing it, and I think most people were doing, ones without necrosis. But it really wasn't until the lumen-opposing metal stent came along that we realized sort of our abilities to go in there and deal with the necrosis and really do better for these patients, especially with necrosis. Because when we would do EUS and see a pancreatic fluid collection, it would be like half of it was solid. We thought this is just not going to go well, and these are going to get infected, stents are going to get clogged. But then came along this lumen-opposing metal stent that was developed by a very smart gastroenterologist out in California. Initially, the tip of it was not hot, it was cold, and you would puncture with a needle. You'd still have to make that 10 French hole and then put the lumen-opposing metal stent in, and then they turned it into a hot axios, which was, turns this sort of 1 hour with fluoro procedure into 2 minutes. Very easy to use, and I would say the majority of therapeutic endoscopists trained in this country know how to use these. And, as you guys know, we're putting them in everything these days. So it's a super easy device, which is why it's been widely adopted, and a lot of us have abandoned the double pigtails because this is just so easy. I mean, there's like 1, 2, 3, 4. It's very dummy proof, and if you generally have a good, nice big bulge, it's pretty easy to put in. So now we're all getting into this direct endoscopic necrosectomy, which, I can sort of seeing all these talks and surgeons going in, it just sounds like a mess. And I think the surgeons love it when we can take care of these patients. They're not fighting us for these. So basically, we can go in and physically debride the pancreas with a variety of tools. There are some that are made like this little, I forget what it's called, the little plastic grabber that can grab things. But as you guys know, the pancreas is just sticky and tenacious, and so we use every tool that we have in the GI lab. We have a lot of foreign body removal tools that you can see here: baskets, snares, tripod graspers, and things like that. So we pretty much use whatever we can. Oftentimes it's cold snare, because we do have to be a little bit careful about blood vessels and things like that. We usually stop their acid suppression. So the thought is once we place the stent that the gastric acid can go in and break down some of the debris. It's certainly essential for us to have imaging prior to the procedure to sort of plan what we're going to do. We look at the collection size, its location to the GI tract. Sometimes they are not amenable. Presence of hemorrhage is important to us. Sometimes it's very obvious, sometimes it's a little more subtle, and we get a little bit worried that if we put this big stent in, that suddenly that pseudoaneurysm is going to start bleeding. We like to get a sense of whether we think the pancreatic duct is disconnected, and again, percentage of solid debris, but that becomes less important as we are able to go in. So this is a video which hopefully will play. So this is actually from a friend of mine, but basically shows how easy this stent is. You can see the internal flange deployed. You pull back the internal flange and then deploy it endoscopically. There it is. The stuff starts pouring out. We can go in, dilate with a balloon if we want to enter the cavity, and then we just go in, enter the cavity, and you can see all the debris. And then it takes like an hour or two to get some of that stuff out. So you look like you have these huge chunks, and then you pull out these little teeny pieces. This is a lovely picture of, sort of what we saw earlier of like Amy pulled out the whole pancreas. That sort of, I would say in my experience, rarely happens. But sometimes you can get lucky and get a big chunk out like that. So the challenge that we have, as you can imagine, is paracolic gutter extension or loculated collections, which can make it very challenging to us. So things that people have tried is using a multi-gated approach where maybe you put one in the stomach and one transduodenally, so you can imagine gastric acid sort of going through, trying to break things up, and it has two ways to exit. Sometimes you try to put very long double pigtails in from the stomach into the fluid collection, sort of down into the gutters to help keep that from loculating off and getting infected. But again, we often need to involve IR for percutaneous drain, and again, as you saw, a possible VARD. So, wait, I went backwards, sorry. So this is a patient that I had a couple of weeks ago who, it always seems like the gallstone patients do the worst. It seems very unfair. 59-year-old man who had gallstone pancreatitis, admitted to an outside hospital, just had the whole everything. SIRS, acute respiratory failure, kidney injury. He had a DVT, was on anticoagulation for a PE, got pneumonia, AFib, and finally was transferred to us with this pancreatic fluid collection that you can see that was extending down into his left paracolic gutter. And it had been about 3 or 4 weeks, I think, by the time he got to us. So this was my initial drainage that I performed, that I got my fellow to edit my videos. So you see a little more endoscopic than EUS image down on the lower left. You can see a fair amount of solid debris, which in the past might have, we might have been concerned that we would cause trouble by draining this. But you can see right up against the gastric wall, we measure, the saddle of the axios is 1 centimeter long, so it needs to be within 1 centimeter. Again, easy peasy. This takes us 2 minutes to do. We advance the catheter all the way in, deploy the internal flange, pull back, and then deploy the external flange. And then you can see on the right is the team, actually the patient was not on the GI service, so the family practice team got a CAT scan afterwards. We typically don't do it, a day later. But you can see extensive amount of air extending down into the left paracolic gutter, and you can see sort of the edge of my stent sitting there in the fluid collection. So 3 weeks later, so the challenge with this is, of course, is that, you have to free up your schedule so that like every week, every 2 weeks, you can go back in if you need to. So this patient was supposed to come back on my schedule in 2 weeks, but I was away at a meeting, so I had to get a colleague who couldn't get him until the next week. But he got readmitted with not feeling well, and probably that paracolic gutter extension probably got a little messy down there. So he came back in, and my colleague brought him back and you can see there's a bunch of garbage in there, and she did some direct endoscopic necrosectomy, and we have her video, but it wasn't downloading, so I'm going to show you one from stock video from the company. We tried this new device called the Endorotor. So it's a metal-tipped catheter that rotates and has a cutting and suction ability. It's a little teeny thing, but you can put it into the debris, and it will sort of roto-root it out. So 2 hours later, she had very nice results. So it's not really quick, but it's kind of a clever new device. I'll show it to you next. So it's this through the scope catheter. It has a controllable rotating cutting edge, and again uses suction. There was a recent prospective trial of 30 patients, and they had no serious adverse events. So it may lessen the number of procedures, but it does take time. And actually it was $1,300 for the catheter, because I had to find out how much that was. I thought, oh, that's pretty good. And then, oh, it's $35,000 for the whole suction and setup. So, not cheap. But if it saved you a couple procedures, maybe it's cost effective. I don't really have that data though. So this was the same patient. So you can see the scope is put way down into the left paracolic gutter through my lumen-opposing metal stent, and then long double pigtails were placed into the fluid collection. So 2 weeks later, he came back. This was about 3 weeks ago, and that looks pretty good. A lot of granulation tissue, still a little bit of debris, which was cleaned out. And then this is the CAT scan 3 weeks later. So that looks really good, don't you guys think? But I'm going to give you the legit CAT scan, which is this scrolled through. You can see the double pigtails. Looks good, looks good, looks good. Now you see a small fluid collection over on the left flank. And then as we continue to scroll, there's this sort of air-filled loculated thing. So, but I think it's got air in it, so I think it's connected. And actually, my colleague today is doing his repeat procedure, so we will have to see. So we can manage these that go into the paracolic gutter. Sometimes we need a little help from our friends, mostly in radiology. So we too do this step-up therapy where we typically put the lumen-opposing metal stent into walled-off necrosis and just allow the initial drainage to occur. And then we usually repeat imaging a few weeks later, and then we manage it based on what we're seeing. If it's gone, great, we're done, we take the stent out. Sometimes we like to make sure that there's not a disconnected duct so the patient doesn't have recurrent fluid collections. So oftentimes we'll do an ERCP or MRCP. And again, our direct endoscopic necrosectomy, when we bring them back, is sort of using every tool that we have in our toolbox. This excavator, that's what it's called, a little plastic thing, a little Pac-Man that you can try. There's studies looking at high pressure water jet, and then this newest device, the endorotor, which, not sure, we'll see. So when we look at minimally invasive surgery versus direct endoscopic necrosectomy, this was a meta-analysis. It was 2 randomized controlled trials and 4 observational studies, a total of 640 patients. Mortality rates were 8.5% for direct endoscopic management versus 14% for minimally invasive surgery, and there was certainly favoring endoscopic approach. On subgroup analysis, there was no difference in mortality in the randomized controlled trials, but improved survival in observational studies. Development of new organ failure was more common in the surgical group, and adverse events favored endoscopic approach. There was really no difference in the bleeding risk, and not surprisingly, shorter length of stay and lower fistula formation for the endoscopic group. So in looking at long-term outcomes, this was a retrospective study that was published in the surgical literature this year, and looking at patients comparing those who had surgical approach versus those with endoscopic approach from a single tertiary care center. And the overall length of stay, again, was shorter for the endoscopic group. Endocrine insufficiency was similar for both groups, but there seemed to be a higher level of exocrine insufficiency in the surgically managed group versus the endoscopic group. So there was a recent study published that this is looking at infected necrosis, which is a little bit different. This was a multi-center trial from 6 tertiary care centers, and they were looking at direct endoscopic necrosectomy immediately at the initial time of getting into the necrosis versus step-up therapy, which is sort of our standard. And they randomized 70 patients. These were infected patients, again, fully encapsulated. And what they found was that there were far fewer number interventions needed for those who they immediately did necrosectomy on versus those where they did the step-up approach. And although there was no difference in overall mortality or adverse events. So this is interesting, and I think, again, it does tend to be, especially with these complex collections, it does require you to have time in your schedule, which, more and more we have less and less time. So it can be challenging, and we're often handing them off to each other just to accommodate these patients. So adverse events is mostly related to the initial placement of the stent, including perforation or dislodgement of the lambs, which is something we worry about a little bit when we put it in, which is why we don't like to go in right away, or I typically don't. Bleeding, sometimes, we use Doppler on the ultrasound probe, but sometimes vessels can be compressed, and the minute that you relieve the tension of the cyst, you can get bleeding. Infection is certainly an issue, stent occlusion and pneumoperitoneum. Some people put double pigtails within the lumen-opposing metal stent, but the data is not really great on that. And again, a lot of the bleeding is related to arterial pseudoaneurysms, which we worry about. And so we've asked our IR colleagues, even if they don't see them, when they do angio, which is not uncommon, to just empirically embolize when we're concerned. Sorry, I went backwards. So in summary, EOS-guided drainage combined with direct endoscopic necrosectomy has really become the standard of care in most major medical centers who have therapeutic endoscopists. And again, these stents, they've gotten bigger. They started at 10 millimeters and now they're 20 is typically the size that we use. But really, we still have challenges with these complex collections, with deep extension into paracolic gutters. And so, we are, I think we have a great group at CASE. I work with Jeff Marks and my interventional radiologist on the regular. And I think a multidisciplinary approach is really the best. And these patients have the best outcomes when we all put our heads together and try and come up with creative ways to manage these problems. Thank you.